first, you want to refer patients to an eye care provider prior to initiating therapy. And I think communication at this point is really important. You need to tell the eye care provider, why they're being referred, what treatment they're getting, the most common ocular toxicities, and also what needs to be done at every visit as well. They need to do a visual acuity. They need to do a slit-lamp eye exam. And these eye care providers need to know that ahead of time so they're doing everything at that visit.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. The advertising messages in this episode are paid for by Dartmouth Hitchcock Cancer Center. 4 seasons, gorgeous facilities, and an amazing lifestyle. The Dartmouth Cancer Center in New Hampshire, one of only 56 NCI-designated comprehensive cancer centers, is hiring. Learn more at dhnursing.org/ONS. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Courtney Arn, nurse practitioner at The Ohio State University James Cancer Hospital in Columbus, about the ocular toxicities, side effects, and reactions that patients with cancer may experience during their disease and treatment. Welcome, and thanks so much for joining us today, Courtney.
Thank you for having me.
So to start off, let's get back to basics. How does the ocular system function in a regular, healthy individual? Let's just kind of talk through that so then we understand how it can change and be different for those that are going through cancer treatments.
The ocular system consists of the eye and its central visual system. When light hits the retina, there are photoreceptors or little cells that turn the light into electrical signals, which then travel through the optic nerve to the brain. Then the brain turns these signals into images that you see. So that's how people are able to see.
So what are some of the most common ocular toxicities that patients with cancer may experience?
The most common ocular toxicities that we see with cancer treatments currently are vision impairment, which can include decreased in visual acuity or blurred vision. We also see keratopathy or keratitis. Very common to have dry eyes, photophobia, eye pain. Sometimes patients can develop cataracts, conjunctivitis, or even blepharitis, which is inflammation of the eyelid.
Are there any specific risk factors that make a patient more likely to experience these types of toxicities?
If a patient has a pre-existing ocular condition, sometimes they can be at increased risk of developing new ocular toxicities while on a treatment. Of course, I mentioned dry eye being a common ocular toxicity. So if someone already has dry eyes, they might be at increased risk of getting even more dry eye while receiving treatment. I'd say the other risk factor is non-compliance with the eye care provider follow-up, which we'll talk about, I'm sure, later in today's podcast, with the optometry and ophthalmology follow-up visits. And then also not adhering to the eye care regimen can increase the risk of developing ocular toxicities.
So are there any prevention strategies that we start patients with in terms of trying to mitigate some of these toxicities?
Yes, we've learned a lot using these treatment options that can cause ocular toxicities, and I think come a long way in how we can prevent some of these ocular toxicities. One of them being the use of eye drops. So there's generally 3 different types of eye drops that can be used: corticosteroid or steroid eye drops, a vasoconstrictor eye drop, or lubricating eye drops. And these can help minimize the ocular toxicities that patients are having. We also have patients see an eye care provider, either an optometrist or ophthalmologist, prior to initiating therapy with these treatments that can cause ocular toxicities. And then we have close follow-up while they're on treatment too, to make sure that there haven't been any changes to their visual acuity or the changes in their exam.
And I know that there have been some recent drug classes that are making ocular toxicities seem more common or more likely depending on what drug a patient is receiving. So can you talk a little bit about those drug classes that are more likely or more prone to cause ocular toxicities?
Yes. The most common treatment right now for gynecologic oncology cancer patients is antibody drug conjugates. Also, it's not as common, but sometimes immunotherapy can cause ocular toxicities as well, but more specifically, the antibody drug conjugates.
So what are some of the long-term effects that could stem from these ocular toxicities that develop during treatment?
Fortunately, most of the ocular toxicities that develop when being treated with these treatments are short-term. And so most of them are reversible, and they actually resolve relatively quickly after stopping treatment that's causing the ocular toxicity. So usually within 1 to 2 months, the ocular toxicities have significantly improved or resolved.
That's definitely good to hear. And it certainly emphasizes the importance of providing that education to our patients and their caregivers of just the importance of, as you referenced earlier, there's some preventative measures and some additional visits and evaluations that are needed to make sure that we're keeping a close eye on those toxicities. But it sounds like for the average patient that they're likely not going to be long-term if they are caught and addressed early.
Correct.
Are there any risk factors for patients to make them more likely to develop long-term effects?
I think the risk factors for developing long-term effects would be, again, some of the compliance, like they're not using their eye drops appropriately, or they don't follow up with their eye care provider like they were supposed to. That can certainly increase the risk of having long-term effects if they're not managing the ocular toxicity that they develop. Also, sometimes patients are hesitant to admit that they're having ocular toxicities in fear of holding or stopping their treatment. So I think that that certainly can lead to more long-term effects, because if we don't know about it and we're not managing it, then sometimes it can be more of a long-term effect, ocular toxicity. But in general, most of them are not long-term and they're reversible.
Absolutely. That is certainly, it seems to be a concern virtually with any side effect or toxicity that we've talked about here on the podcast, is just making sure that we set those expectations with patients and clarifying that whatever dose we start you on, being on this dose long-term is not the ideal dose for you if it's causing these types of side effects or critical toxicities that are causing additional or potentially worse problems. And so setting those expectations up with patients of the importance of being honest and being transparent of what they're experiencing so that we can then appropriately adjust, whether it's their additional, their pre or post medications, any sort of supportive medications that we can provide, or potentially, changing the dose or the treatment if we need to. But that conversation is continually important because, yes, we do see patients who sometimes don't admit to how bad side effects are because they do fear like, oh, if I have to change my dose or hold my dose, like that will impact the effectiveness. And we just have to keep clarifying the importance of that.
Exactly. And I think that's why patient education is really important, even prior to starting the treatment, talking about the potential toxicities, reason to be calling for, and making sure that they know that, like, just because you develop these doesn't mean we're going to stop the therapy. We have a lot of mitigation strategies to help manage them. And then also, even on the clinical trials, patients had to be dose reduced or hold treatment temporarily, and we are still seeing results. So I think it's good for them to hear that ahead of time.
So it might seem pretty obvious, but how do these ocular toxicities typically present in patients?
Sure. Well, it can happen one of two ways. Sometimes patients come in and they say, you're asking them, are you having any new symptoms, or do you have any blurred vision? And they'll say, I haven't been able to see my computer as well, or I've noticed when driving, I can't read the road sign. And one I really hear often is watching TV, they can't see like the scores of sports games at the bottom of the screen. And so sometimes it's like asking the patients. Other times they'll call and say, I'm having a change in my vision or a new ocular symptom. And then another thing that can happen is patients can come in and have no side effects at all, but we'll review their optometry or ophthalmology progress note and note that they have had changes in their eye exam, or the patients have had decrease in their visual acuity that's picked up just on the ocular assessment. And so they might not be complaining of any symptoms, but when reviewing the eye care provider's note and assessment, that we pick up on new ocular toxicities then.
So what is involved and kind of what is the nurse's role in that workup and documentation for a patient who presents with symptoms they are noticing that could relate to ocular toxicities?
Yeah, nurses play a really important role in the management and identification of these ocular toxicities. In regards to documentation, they document in a progress note if they're having any new ocular symptoms, and then they notify the provider prior to them getting treatment. At Ohio State, we have a smart phrase that our infusion nurses generally use, but sometimes the clinic nurses will use also. And it essentially asks, are you having any new eye symptoms? Are you using your eye drops as prescribed? And did you see your eye doctor before today's visit? And so the nurse fills that out prior to them seeing a provider before their treatment that day, so that the provider is able to review that, identify if they're having any new ocular symptoms, or if they were supposed to see the eye care provider and they did not. That's easily identified prior to sending them back for their treatment. This has really helped with our flow. I think a lot of our oncology nurses get used to the same toxicities from treatments that we've had for several years. And with these new treatment options that we're finding for our patients comes different side effects. And in the past, ocular toxicities or asking about vision has not been a part of the toxicity assessment or the nursing assessment for these patients. And so I think utilizing that smart phrase has been really helpful. It helps the nurse, make sure that they're asking the right questions. It helps the provider make sure that everything's been addressed prior to giving treatment that day.
I think that you bring up a really important point of just this being new for us as well, being new for nurses in oncology. This is not a standard side effect or toxicity that we've seen over, the decades that we've been treating patients with some of these active therapies that we have. And so it is important to understand which drugs, and as you referred, immunotherapy puts risk. The drug conjugates also create that risk. And so just understanding what drugs we're infusing for what patients, and then creating, as she said, those reminders, smart phrases, things that help to connect the importance of this new uncommon assessment up until now, so that we're not missing this for these patients who are receiving these types of therapies.
I think it's really important.
So when the ocular toxicities present, how are they typically managed?
It depends on the ocular symptom that they're having. Oftentimes, the eye care provider, either the optometrist or ophthalmologist, does primarily management of their ocular toxicities. If it's blurred vision, sometimes they'll recommend different eye drops. If it's a decrease in their visual acuity, sometimes we need to hold or dose reduce their treatment. So essentially, that we kind of rely on the eye care provider to identify what this new ocular toxicity is, the severity of it, and then depending on how severe it is, we either hold, dose reduce, or permanently discontinue. But then we allow the optometrist or ophthalmology to kind of manage the specifics. So if it's conjunctivitis, oftentimes they will be treating the conjunctivitis. The oncology office is just responsible for identifying, okay, they're having this new ocular toxicity. Can we give treatment today? And if so, do we need to dose reduce?
Yeah, let's talk a little bit more about that referral process to ophthalmology, just working with our patients and collaborating together for ocular toxicities. Something, as we already mentioned, something we haven't classically done. We're used to collaborating and referring to lots of specialties, but ophthalmology has not historically been one of them. So I think this is a very interesting development. Can you talk a little bit more about that process?
Yeah, it definitely takes, collaboration from everyone at the oncology office, from the scheduling to patient navigators to nursing to APPs to physicians, and the collaboration. So first, you want to refer patients to an eye care provider prior to initiating therapy. And I think communication at this point is really important. You need to tell the eye care provider, why they're being referred, what treatment they're getting, the most common ocular toxicities, and also what needs to be done at every visit as well. They need to do a visual acuity. They need to do a slit-lamp eye exam. And these eye care providers need to know that ahead of time, so they're doing everything at that visit. A lot of these newer treatments also have ocular assessment forms that we send with the referral also. So it identifies that in the referral, exactly what needs done at each visit. And then it forces them to say, if they're having keratitis or conjunctivitis, and if so, how severe it is. And that way we're able to identify if it's safe for them to continue to get treatment. The nurses also play a role in making sure that not only do they see them for their baseline eye exam, but if they're required to see them before each infusion or every other infusion, whichever the institution is doing, making sure that we got that progress note or the ocular assessment form from the eye care provider, making sure that there are any issues before they come in for their treatment visit. So similar to, making sure their labs are in or okay for treatment, we're now having to check off to make sure that they've seen the eye care provider and we have that documentation prior to them coming in. And then if a patient calls in, oftentimes our nurses are taking these phone calls and saying I'm having these new symptoms, and they're helping coordinate with getting them in to see the eye care provider before their next visit.
And that's very important. I think it just highlights how collaborative care for our patients with cancer diagnosis truly has become. And I think we've known this and seen this expand over the years. But now with these newer toxicity types that are engaging with other subspecialties, it's even more important than ever to have that relationship with these other offices, providers, their staff, so that not that we would send every patient to a single doctor, but if there are certain doctors that are more comfortable or more familiar with these types of therapies, and that can be a nice connection and relationship to establish with another office so that they understand what's being asked and they know, when to notify the oncologist in their office if they're seeing new acute problems that are really concerning. It just helps to establish those relationships so that back and forth communication can be succinct and be efficient and ultimately provide the best care for the patient.
I think, again, the nurses are very important in this process from the beginning of doing the patient education prior to them starting therapy, helping with the referral process to getting them in, making sure the patients have their eye drops, making sure they know how to use their eye drops, making sure they're aware of the signs and symptoms to be calling and reporting, and then also identifying at their visits too if they're having any new symptoms. So they definitely play a heavy, heavy role in this process.
The Dartmouth Cancer Center is one of the nation's premier cancer treatment facilities and is an NCI-designated comprehensive cancer center. Nurses have access to amazing treatment protocols, clinical trials, and a team of remarkable people focused on the highest levels of oncology care. Nurses can expect generous sign-on bonuses, loan forgiveness, and relocation. Life works here with amazing four-season living in the gorgeous mountains of New Hampshire. Learn more at dhnursing.org/ONS.
You described, I think, perfectly how integrated and involved the nurse and their role is in this collaboration across disciplines. What are some of the most important educational points that likely nurses are heavily involved in communicating to patients and their caregivers about these ocular toxicities?
I think first they need to talk to them about the potential ocular toxicities in general. There is a risk of ocular toxicities. These are the most common ones for the treatment that you're receiving. This is when I need you to call. These are things I need you to be looking for. Making sure that they have an eye care provider, making sure they have the resources and means to get the eye drops that are prescribed. And again, talking to them about how to use eye drops. A lot of our patients have never had to use eye drops before. So just going over the basics, and oftentimes at their first infusion visit, I have the nurses kind of go over with them exactly how to put the eye drops in and making sure they're doing it appropriately. And then also making sure that they're aware that they need to see an eye care provider and the follow-up care moving forward. And then I just think talking to patients about the signs and symptoms to be looking for at home and giving them precautions.
Yeah, I think you brought up some excellent points about just emphasizing, I guess, the importance of these visits to the ophthalmologist. Many patients might come into their experience getting a cancer diagnosis. Maybe they have the eye doctor they see just for pretty benign reasons, getting glasses or contacts, those types of things. But I think it is important to create that distinction of the importance of these visits, how they're different and more frequent and needed compared to what they maybe were accustomed to before, and just emphasizing the importance of keeping those appointments and keeping in touch with their ophthalmologist so that those issues can be identified early and communicated to the oncologist. I think that's just a very unique experience for patients. And so I think everything that you've described in terms of communicating that, making sure they have access to an ophthalmologist, they know who they should go to. If they don't have one already, who should they go to? Can we help facilitate that? And as you mentioned, with all medications, if these eye drops are unique or expensive, or they have access issues of getting them, whether it's financial or transportation to get these eye drops from their pharmacy, just all of those barriers to receiving the right care is something that we have to make sure we assess and address so that patients can maintain these appointment schedule and stay adherent to the recommendations that we're giving them.
I mean, sometimes it's hard enough to help our patients get to their appointments for their treatment, and then adding another visit on top of that and other prescriptions.
Absolutely. Yep. Something that we have to just stay vigilant on. Well, Courtney, thank you so much for overviewing this topic for us. I think as we talked about, it's something that's relatively new for our oncology nurses. And so being able to shine some light on it and explain some of the nuance of why ocular toxicities are sort of uniquely appearing now and how we can help mitigate them, I think this has been very beneficial. I've certainly learned a lot. So as we move into the end of our episode, we'd like to finalize our discussion with some of our quick fire questions just to help summarize and wrap up some of the things we've talked about. So to start that off, how do you think healthcare professionals should evaluate maybe their hidden or implicit bias concerning ocular toxicities?
I think a lot of people aren't willing to admit it or even acknowledge it, but it is scary to hear, that treatments can cause ocular toxicities. And I think in the past, oncology teams have been hesitant to manage blood pressure and other toxicities too, but now we're much more comfortable. And I think eye care will be the same way. I think at first it's something new, something we're not used to, and it can be a little bit overwhelming. So I think acknowledging that it's scary, it's new, but it's also very manageable. I also think it's okay to rely on the eye care providers for the bulk of it. They're going to be doing the assessment. They're going to be identifying how severe their ocular symptoms are. And then based on that, is it okay to give treatment? I also think that the ocular toxicities that we're seeing with these antibody drug conjugates specifically are fairly mild, the primarily grade 1 or grade 2 with very few of the patients having grade 3 or grade 4 toxicity. So while it is scary and there are new ocular toxicities, it's not like, all these patients are having severe vision loss or insane ocular toxicities that are really challenging to manage. And I just think the more we start using it, the more providers are going to be comfortable with it, have that closer communication with eye care providers. They'll start to form relationships with different eye care providers in the community and kind of rely on them, just like we refer our patients to cardiology or endocrinology. It'll become very similar to that.
Absolutely. I couldn't agree more. What are some common misconceptions about ocular toxicities?
I kind of alluded to it earlier, but I think a common misconception is that half the patients are having severe vision loss or long-term effects and that these ocular toxicities are really hard to manage. And I don't think that's the case. Yeah, severe vision loss can happen, and that's why there's boxed warnings on a lot of these treatments. But again, for the most part, the ocular toxicities we're seeing are grade 1 or grade 2. They're fairly basic ocular conditions like conjunctivitis, blurred vision, dry eye. So it's not something super complicated that only a special eye care provider who's familiar with antibody drug conjugates can manage. It can be an optometrist or an ophthalmologist. And these are eye conditions that they're seeing every single day and they're very comfortable managing. So I think the severity of the ocular toxicities, the management is a little bit overwhelming too, but just knowing that optometrist, ophthalmology are going to be doing the bulk of the management of the ocular toxicities. And then again, just knowing that most of these ocular toxicities are reversible. Patients are seeing at least improvement, if not resolution of their ocular toxicities. And most of the patients aren't having long-term effects.
I really like how you just provided that example of bringing in the ophthalmology and the eye care providers into our care team. You help them understand that they are playing a really important pivotal role in caring for our patients that are getting these types of drugs that bring this risk.
Yeah. And honestly, like the optometrists and ophthalmologists have been very helpful. I think they feel rewarded in being able to help these cancer patients stay on a treatment that's working for them. And, their job, sometimes they're doing the same thing all day, every day, and to add something new and them learning about it. I think that they've really been excited about it. And my experience so far has been great with them and they've been wonderful to work with.
That's awesome. I love hearing that. What's something about this topic that's not often discussed, but you wish people knew more about?
I think that we focus a lot on like steroid eye drops or vasoconstrictor eye drops and how that can help reduce ocular toxicities. But we don't talk about is like the lubricating eye drops. The lubricating eye drops can really help minimize some of these ocular toxicities, especially the dry eye. So I think that that's something that we could talk more about. I also think the question of does someone need to see an optometrist or an ophthalmologist is a very common question that a lot of people don't know. And like I said earlier, it can be any optometrist or ophthalmologist. It doesn't have to be a specialized eye care provider who's familiar with oncology patients or antibody drug conjugates or any other treatment that can increase the risk of ocular toxicities. And then lastly, I commonly get asked, and I don't think there's very much data out there about this, is like how it's billed. The first question patients always ask me is, I can only see my eye doctor once a year. How am I going to see them more often if I'm having problems? And it's billed through their medical insurance, not their ocular insurance. And so I think that that's something that I wish people knew more about too, because I think that hesitancy for some providers and also patients in receiving these treatments.
I'm so glad you brought that up because that was a question I had. I remember when some of these drugs were first coming out, and that was my first instinct. I'm like, well, a lot of people don't even have vision insurance, let alone vision insurance that covers these multiple visits. And so I really appreciate you bringing that up so that not only nurses can learn that, but that we can share and sort of hopefully address fears or concerns from patients that this would be billed in a different way because it isn't this routine preventative, just general eye care. It is specific to a medical condition. So that's a really important point, and I'm so glad you brought that up.
Thank you.
What additional training or education do oncology nurses need to help stay current on this topic?
I think just being aware of the potential ocular toxicity, identifying which treatments can cause ocular toxicity, what the most common ocular toxicities are, also when to refer to optometry or ophthalmology. Also, like adding it to their toxicity or nursing assessment. Like I said earlier, a lot of nurses have been in oncology for a really long time and they're kind of comfortable with the routine, like questions that they're asking these patients receiving treatment, and just adding that to their list of questions that they're asking, because this is different than other treatment options out there for oncology patients. So being aware that it can cause ocular toxicity. So if a patient, in the past, if someone called in with like vision changes, we'd often just refer them to go see their eye doctor and not think that it's cancer or cancer treatment related. So just being familiar with which treatments can cause it, the most common toxicities, make sure that they're educating the patient, and then also just adding it to their nursing assessment.
And I like how earlier you brought up the use of smart phrases. So knowing that a lot of our assessments are kind of set up, kind of baked in a certain way in a certain format for the most likely, needs or certain systems you need to address. So working with your informatics department to understand, are there ways to help, as you said, use smart phrases, trigger certain things to appear based on other documentation or drugs that are being given? Just important to make sure that that can be optimized so that it is easy for the nurses to access and that they can do that documentation as part of their regular workflow.
I agree.
And then finally, what are some additional resources maybe for patients or other healthcare professionals who want to learn more about ocular toxicities?
Honestly, I recommend visiting the specific drug that you're using's website or looking at their package insert. I'm pretty familiar with a lot of the treatments from the clinical trials, things like that, but I still often find myself going to their website frequently because right on their website, they have like the most common ocular toxicities. They have safety information. They have all the resources available as far as like the ocular assessment forms, referral process, all of that's right there in there. So I think that just visiting that website has been like really, really helpful. And then utilizing these referrals. So like discussing with pharmacy, talking to the eye care providers, things like that, just to learn more and more about the ocular toxicities.
I think that's great advice. And a lot of our industry partners who are creating these drugs are creating not only information to help teach us as clinicians, but also they typically provide great patient-directed tools to help them not only understand the drugs they're receiving, but for like if they have a complicated eye drop regimen, they might have tools that help kind of keep that patient organized and what they've taken and how they've taken it. So I think that's great advice to always look to the website of the company that's created the drug to see what tools that they have already tried to create to help make this process easier. Courtney, thank you again. I learned a lot on this episode. I think it's a topic that a lot of nurses are encountering more often, but maybe didn't know a lot about. So I think you've definitely helped bridge that gap in knowledge. Do you have any final comments to share with our listeners today?
I can't reinforce enough how important like collaborating is and just this is a team effort, knowing who's responsible for referring to the eye care provider, know who's responsible for making sure that we receive the ocular assessment form or the progress note from the eye care provider, who's going to be doing the patient education, who's prescribing the eye drops. And all of those things are really important to just kind of identify whose role is doing what at each institution because again, it's new and it's a little bit overwhelming, but once you do it a couple of times, it becomes very comfortable, but just acknowledging like who's responsible for which task to make sure that these patients are getting the care that they need for these treatments.
Wonderful. Very well said. Well, thank you again, Courtney. I really appreciate your time.
Thank you.
4 seasons, gorgeous facilities, and an amazing lifestyle. The Dartmouth Cancer Center in New Hampshire, one of only 56 NCI-designated comprehensive cancer centers, is hiring. Learn more at dhnursing.org/ONS. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.